So happy to be able to add her back onto our schedule. So without further ado, here's Dr. Dodd.
All right, so like Dr. J was saying, it's our great pleasure to have Dr. Fiscus here today. For those of you who don't know, Dr. Fiscus is the medical director for the Tennessee Department of Health for the Tennessee Vaccine Preventable Diseases and Immunization Program. She also sits on several AAP committees dealing with immunization. Dr. Fiscus and I were speaking briefly before the presentation, and I think she was saying she has a career overview in her slides, so I don't want to take the wind out of her sails, but I think we all really appreciate her coming, and I'll turn it over to you, Dr. Fiscus.
Thank you. Thanks very much, and I'm happy to virtually be with all of you. I was pretty bummed when the trip in March got canceled because I enjoy coming out to ETSU and being able to spend some time with the residents and attendings there. So at least this is, you know, one way that we can manage to get this done for now until I can get up there myself. So I thought I would start with just a little bit of background on me because my path has been a little bit weird. And I like to share it whenever I'm talking to residents or medical students, just because I didn't find my way until I was about 48. So if you're sitting there in training or in medical school or in your career and you know, stressed out about not exactly knowing what path you're supposed to be on, this current path for me didn't start until about 3 years ago. I went to medical school and did my residency at Indiana University in Indianapolis and trained at James Whitcomb Riley Hospital for Children there, and really wanted to do infectious disease work, specifically clinical epidemiology. And I'm you know, fairly ancient, so we're talking mid-90s. At least the program I was in didn't really have an MPH program to speak of. I didn't know what an MPH was or really understand public health aside from that's where poor people go to get shots. And so it really wasn't anything that was even remotely on my radar. And I looked at doing infectious disease fellowships, and all of the ID fellowships usually require somewhere between 18 and 24 months of bench research, and it can't be clinical, or at least then it couldn't be clinical research. And I knew I would die a slow and miserable death doing bench research for a year and a half or so. So that just wasn't a good option for me. So I went the critical care route, decided that I would do a fellowship in pediatric intensive care, and then got some advice about burnout in peds critical care, and was encouraged to do something alongside that. So I decided to come to Vanderbilt and do a second residency in anesthesiology at the same time I was doing a pediatric critical care fellowship. And that was going to be another 5 years after my peds residency. And this was in the late 90s, where anesthesia just kind of had the bottom drop out of it, and everybody was losing their jobs. The CRNAs were really coming on the scene, and the chair at Vanderbilt left, and it just kind of became a disaster. And that's where I also learned that I really have a hate for adult medicine. And I just could not do it. I'm a pediatrician. It's in my DNA. I have an ER behind me in my office at the State Department of Health. They're actually all over my office. And I just couldn't do knife and gun club, middle of the night, transfusing the blood bank into somebody who shot a cop kind of medicine. It just wasn't for me. So I left after about a year, and I joined a practice. And as some of you who are getting ready to leave your training, or maybe second years who are thinking about what that might look like. I was afraid, I think, that I wouldn't get a job, and so I took the job that was offered to me. I didn't negotiate the contract. I made some mistakes in doing that, ended up in a really bad practice situation. And that practice had kind of a hostile corporate takeover, and I went from being a partner track pediatrician to being an employed pediatrician who was treated pretty poorly. The other doctors in my practice and I had a parting of the ways with the corporate part of the practice, and that didn't go well. They locked us out of our practice one night and escorted us all there to get our things and leave, locked the doors, put new doctors in the next day, and I was then an unemployed pediatrician, which wasn't something that I had really ever had on my radar. So one of the other doctors there at that practice and I decided that we would just go it ourselves, and so then I became a business owner in 1999, which is also not something that I planned to do, and it was in general pediatrics, which was something that I also had not planned to do as a critical care / wannabe infectious disease / possibly anesthesiologist as I had trained. So I spent 17 years running my own practice with one partner. That was an interesting and challenging time. Medicine has changed a lot over the last 20 years with insurance companies having more and more control, more and more hoops to jump through, the cost of running a practice increasing, the difficulties around procuring things like immunizations. When you think about immunizations are the world's worst business model, that you purchase a product, you inject it into someone where you cannot retrieve it should they decide not to pay the bill or their insurance not pay the bill, and then you pay the company for those vaccines that you just purchased. And so it's a terrible business model if you're trying to run a business, and was always a challenge for us to be able to keep up with that. Let me clear my throat for a second. So we did what we could. Sorry. We did what we could to get through that. I also was practicing in Williamson County, which in Tennessee is sort of the hotbed of the anti-vaccine movement. And at one point, I just started to really lose heart for being in medicine and suffered from burnout in a really big way. And kind of had an existential crisis around the practice of outpatient medicine, in that, you know, I would have these parents that would come to me where I would recommend that their teenager get an HPV vaccine or a meningitis vaccine, and their response would often be to me that they were not going to provide their children those vaccines because they didn't trust them, because they heard they caused sterility, because they heard X, Y, and Z. And that was really difficult for me to work with families that I'd been working with for maybe 10 or 15 years, and then have them say to me, you know, basically, we think you might give our children something that would harm them. And I really just sort of had this soul-searching kind of moment and decided that I just didn't think I could do this anymore. And I've been very open and vocal about my process through that and through burnout and all of that, because I think it's really important for people to hear that people go through that and that you can come out of that and do something different. So kind of in one of my really big moments of desperation where I was trying to figure out, you know, do I go work for an insurance company? I didn't think I could do that. I didn't want to work for a pharmaceutical company. I'm not a very good cog in a big wheel kind of situation because I can be kind of vocal about things. So I wasn't sure that going to a large medical center would be a good option for me. And then one day I happened to get an email from Dr. Morgan McDonald, who is at Tennessee Department of Health, who's also a pediatrician, med peds, asking if I knew anyone who might be interested in taking a deputy medical director position in their division of family health and wellness, and asking me to pass that offer along, which I did not pass along, and reached out to a good friend of mine who I had actually mentored in my practice named Dr. Michael Warren, who at the time was Deputy Commissioner of Health at Department of Health. He thought I could be considered, and he said that he thought that they might think about it. And as the state works, about 6 months later, I finally got a job offer because things move really slowly here. But in the process, I had to go through basically a business divorce with my one partner, and make some really difficult decisions to do that. But I have been here now for 3 years. I spent 2 years in family health and wellness, overseeing their chronic disease prevention, health promotion, tobacco, infant mortality, maternal mortality, cancer programs, some other things probably. And then last fall, a year ago fall of 18, had the opportunity to come to the immunization program, which was really kind of a dream offer. And so in this program, not only do I oversee the management of the Vaccines for Children program, but I also work in vaccine preventable disease outbreak response and mitigation, which is exactly what I wanted to be doing about 25 years ago. So I got there. It just wasn't in a super quick way. But now, when we had a measles outbreak last year, I was the one coordinating the response to that, to the hepatitis A outbreak that we've been dealing with. And right now, I'm in the group of folks that are managing the COVID-19 outbreak response in Tennessee. The interesting thing about this is that it's handled a little differently from other outbreaks that we've managed here. But so that's a very long-winded introduction to who I am and what I'm doing. And I'd like to talk a little bit about what's going on with COVID-19 from what we're seeing from a state level perspective, and then also talk a little bit about where we are with vaccine development, and also about how COVID-19 seems to be impacting kids. So hopefully I'll leave some time at the end of this to get some questions. Here's my disclaimer. I don't get any money from anybody. I'm funded by the CDC. When we have an outbreak or anything that's health related on a large scale like this, Tennessee Department of Health stands up what's called our incident command system. And so we did that on January 15th when we first recognized that there were cases of COVID-19 that were being identified in the United States. And so that was 119 days ago. It took a couple of months before we got our first case, which was March 5th of last year, or this year, feels like last year at this point. And I was the unfortunate person who happened to be on 24/7, 7-day call at the time that COVID-19 hit the state of Tennessee. So the very first person who ended up being diagnosed with COVID-19 called me the day that he developed symptoms after traveling to a conference in Boston. And we talked about how he probably needed to go get tested, and then his test result came back the next day. And I have never been on a more miserable stretch of call than that first week of COVID-19. I still have sort of PTSD from that whole call experience. And it was so bad at some times that while I was answering one call, I would get 5 voicemails at the same time, and that went on for days and days. So we've since had to break up the way we take call here in the disease outbreak section because it's been a little bit taxing. Just to give you an idea, so we actually have a kind of a big org chart when we set up an incident command system, and this is our COVID-19 org chart, which is huge. And so it starts up at the top with the governor and the unified command group that they've set up, and then comes down to our mission coordinators, and then we have what's called DACO and ADACO, which are kind of the leads here at Department of Health, and they break out into branches, which have all of these sub things. And so this is a massive, massive response. And it's different than other responses that we've led, for example, like measles, because when typically, say, when a measles outbreak happens, that comes to the Department of Health, and we manage that response. With this response, the state declared a state of emergency, and when a state of emergency is declared, then that all shifts to TEMA by law. And so TEMA, Tennessee Emergency Management Agency, is the one who ends up coordinating the entire response. So instead of Department of Health really running the whole show, we are now sort of an advisor and sub-entity underneath this huge TEMA response, which has been challenging for all of us to try to figure out how to do that, because TEMA is really good at responding to things like tornadoes. They are finite events that happen, and then you go in and you clean up the damage and you restore the power and you make sure people have housing and shelter and all of that. But this is very un-TEMA-like in being this huge, probably years-long response with this ongoing contagion that is not really something that TEMA is used to managing. So it's taken us a little bit of time to figure out how to work together. TEMA likes to make a decision and go and act on it. Department of Health likes to mull things over for a while and think about all of the collateral damage and things that could happen down the road based on our response. And so we're trying to slow TEMA down a little bit, and they're trying to speed us up a little bit. And it's taken actually several weeks, a couple of months, for us to really start to get in a little bit of what they would call a battle rhythm to get this going and for it to be really well coordinated between the two agencies. This is just a snapshot of what the United States is looking like with respect to its epi curve. So we're the yellow line way up here at the top, and this is a logarithmic scale. So we've got countries like South Korea in red, who have pretty much plateaued here. The purple line is Iceland, who, man, they came out and just had a tremendous response to their COVID outbreak and really got it under control very quickly. The United States still has a very vertical kind of epi curve as we're looking at it, and especially compared to the other countries that we see. We have more cases per capita, we have more deaths per capita than any other country in the world at this point that's reporting data around COVID-19. And then this is where Tennessee stands with respect to our neighboring states. Whoops, missed that one. So we're sort of here in the middle of the pack. There are states like Virginia that have more cases than we do, states like Arkansas that have way fewer than we do. But for southern region states, we're sort of right here in the middle. Every day at 2 o'clock at tn.gov/health, we post the day's most recent counts. So yesterday we were at 16,110 cases that had been identified. That was an increase of over 1,000 cases in 48 hours, which is concerning. About an increase of about 2,000 cases between last Thursday and yesterday. We've had 264 deaths, and we've done about 283,000 tests right now. Right now, there's now only one county that has escaped reporting a case, and that's Hancock County up by you guys. They are 92nd in the population for the state, and they've had no cases. Actually, their testing numbers up to about 96 now, I think. So statistically, they should have had probably 5 or 6 cases by now, but they're not very populous, so they're probably a little better at spreading out than the rest of us are. Pickett County, which is up here, it just got a case, and it is the lowest populated county in the state of Tennessee. And this is what our epi curve looks like. So the red line is the trajectory of cases. You can see that there's not really so much of a leveling off. You can't really look at the part of the curve that's in the gray box because we still have cases and numbers coming in from that. We have about 8% of our identified cases that we know have been hospitalized, but about 40% of those cases we still don't have that information on. I did want to draw your attention to the disparity here, that we have 21% of the cases in Tennessee have been identified as being among the African American population, and they're comprising 31% of the deaths. So the population of African Americans in the state of Tennessee is about 17%. So they are far outpacing what their proportion of cases and deaths should be. Part of this might be because a large concentration of the cases are in metro areas, like the Metro Shelby region and Metro Davidson, where there's a lot more crowding and where the minority populations are higher compared to the rest of the state overall. And then this is also underlying the continuing disparities that we have with respect to access to care, care for chronic conditions. We know that people who have diabetes or asthma are more likely to die from COVID-19. So all of those comorbidities that disproportionately affect those populations are playing a role in their morbidity and mortality around COVID-19 as well. We've tested approximately 4% of the population. I say approximately because some of those 280,000 tests have been done in the same person more than once, but we don't have a good beat on exactly what that duplication number looks like yet. We're running about 5.7% of our tests as positive, and that number has continued to drop, which is a little bit reassuring. At the beginning of the outbreak, we were somewhere around 7.5% to 8% positivity rate. 5.7 is the lowest that I've tracked it so far, and that's partly because we started testing asymptomatic individuals. So originally, in the first few weeks of this, we were only testing people who met certain criteria. They had symptoms. They were hospitalized with ARDS without an explanation. They were a contact to someone who was a diagnosed case. But then in April, we liberated the testing, started standing up public testing sites, and started getting a lot more asymptomatic individuals coming in for testing. So that has dropped the positivity rate down. Our death rate is about 1.6%. That's been pretty stable even back since March. It's been about 1.7%. And 85% of those deaths are occurring in the 61 and older population. Kids are relatively low in number. We've had about 2% of the children, 2% of the cases that are children in their first decade, about 6% are children in the second decade. And we're seeing that teenagers and young adults really act more like the rest of the adult population with their ability to contract coronavirus and exhibit symptoms of COVID-19. So once you're getting into those teenage years, we're really starting to see them act more like adults, and so we're getting a rate that's more consistent with what we see with adults. As far as testing goes, there's a lot of questions about testing, probably a lot more questions than answers at this point. So the FDA puts out something called an emergency use authorization. And what that means is that the FDA has reviewed, superficially reviewed the testing to make sure that it checks certain boxes that they have, but it's not a full FDA authorization kind of situation. So the market is flooded with tests, many of which do not have even this minimum FDA emergency use authorization status. There are no CLIA waived serological tests. So when you're hearing about people who are getting point of care serology testing, none of those have FDA EUA status. So we really don't know what kind of tests those are, what their sensitivity or specificity look like. What kind of lab is doing it. We have lots of labs and businesses that are in the business of completely different kinds of industry that have decided that they're going to stand up some kind of testing platform for COVID-19. So it's really important to understand what test was done, what test you're dealing with, so that you understand what the limitations of that test might be. There are 12 serologic tests that have FDA EUA and 56 molecular as of today. That list changes every day. There are 4 CLIA-waived molecular tests that actually look for the presence of the virus that are available, that are out there and being used in some clinics, and they have varying degrees of reliability as well. Most of those molecular tests are nasopharyngeal or oropharyngeal tests done with a swab. But there is one saliva test now that has FDA EUA that is done out of Rutgers University in New Jersey. And so people can literally spit in a tube in their house and send it to Rutgers and have molecular testing done to determine if the virus is detected there. That will be really nice if that ends up being a test once we get large numbers that can be done, as obviously it reduces the amount of PPE that we burn through. It helps to protect some of our healthcare workers by allowing people to get tested at home. It would obviously be much easier for people to test at home, and it's a relatively technically easy test to do, to spit in a tube, as opposed to trying to get a nasopharyngeal swab, which, if done well, feels like a brain biopsy and is really difficult for an individual to self-administer. So the testing situation changes every day in the state. With the serologic testing, so this is looking for antibody, whether that's IgG or IgM antibody. Most of the tests that are available are not highly specific for the SARS-CoV-2 virus. So they may be detecting antibodies to normally circulating coronaviruses that cause about 20% of the common cold. So you have to be very careful about how antibody testing is interpreted, especially if it's being interpreted outside of a clinical trial or a study, an actual study that's being done, because we have no way of knowing about the specificity of the test that's being done. We also don't know if antibodies detected, if it's neutralizing to the virus. Obviously, we get antibodies to HIV if we're infected with HIV, but those HIV antibodies are not neutralizing. People are still infected with HIV, even though they have circulating antibodies. Same goes for hepatitis and many other diseases that we see. So just because we can detect antibody doesn't mean that it is protective against developing infection to this virus. And if it is protective, we don't know how long it lasts. So while we hope that there is long-lasting immunity, and we know that antibody is created when you're infected with SARS-CoV-2, we don't know if that's 6 months or a year or a lifetime that antibody lasts. And if it's read the playbook from the other coronaviruses, it's not going to be a long-lasting antibody. This virus hasn't read the playbook in a lot of other ways, so we're hoping that maybe it won't have read that one either. But antibody testing at this point, from what we know right now, is really best reserved for population-based studies that are done to try to look at the incidence of the disease in the community, and to try to do the studies that are needed to determine whether or not that antibody is protective and long-lasting. It really can't be used on an individual basis to inform behavior. So when we talk about, or when we hear about immunity passports, where if you can show that you had immunity to SARS-CoV-2, you might be able to travel more freely than someone who cannot demonstrate that immunity. That's really carrying this a little bit further than, or a lot further than what we should be, judging by what we know right now. Same goes for universities that are talking about opening up in the fall. Some of them, Purdue University put out a statement that they were looking at maybe antibody testing all of their student body, and then cohorting the housing based on that, or cohorting the classes based on that. And again, we really don't have reliable information that would make us feel comfortable saying if you have detectable antibody that you're protected and should be cohorted in that way. The molecular testing that we do, which is looking for the RNA of the virus or looking for the antigens, is a snapshot test. There's a high false negative rate because of the technique that's involved in obtaining that specimen. It has to be done just right. It has to be done with a polyester or some other synthetic kind of swab. Really, the most reliable are taken from the nasopharynx, which is uncomfortable, and children are not readily going to tolerate that. And just because we have a negative PCR test today doesn't mean that it would be negative tomorrow. So really, it only tells you what your situation is at that particular moment with about 50 to 70% accuracy. So it does help us in determining when to isolate patients and contact trace and quarantine their contacts. And that is how every good response to an infectious disease outbreak has ever been run, is by identifying the sick and isolating them and contact tracing and quarantining their contacts. But a negative isn't as reassuring as we would like it to be. FDA has started posting the sensitivity and specificity of their antibody testing that has received FDA EUA, which is kind of nice. So the Abbott Architect, which is one of the platforms that we have here at the state looking at testing populations around antibody, has very high sensitivity and specificity for the SARS-CoV-2 virus, which is great. This is an IgG test, which is thought to be much more valuable than getting an IgM test on someone. But these tests cross the spectrum of quality. So you can see this Cambrio diagnostic system, which looks at IgM and IgG, has relatively low specificity and sensitivity, and makes it much more difficult to interpret the results of that test. And again, there are no CLIA wave tests to do antibody testing as of right now. There have been a couple of interesting antibody studies that have come out. So Major League Baseball just completed a study where they sampled players and staff from 26 of their 30 Major League Baseball teams across the United States, and those tests were conducted in April. They ranged from 20 to 64 in age, but these were, obviously this is a biased, selection biased community. They're elevated socioeconomic status. They're all employed. Some of them are very, very wealthy. But they looked at 5,700 players and staff. Only 60 of those tested positive, which put it at 0.7% positivity rate in this population. And they noted that 70% of those positive were asymptomatic. So my first thought about this study is, what kind of test did they do? And I couldn't find it from any of the publications that I saw, and this has not been peer reviewed or published yet. So I was having to go off media reports. But one of our laboratorians, her husband is a writer for baseball, who was able to dig a little bit and found out that they used an antibody test that does not have an FDA EUA and is not from a manufacturer that usually does antibody assays. So it is highly suspect that this test had a very high false negative rate, and that we probably can't use this as any kind of generalization, both on the sample bias and also on what we suspect might not be very good testing sensitivity about the incidence of disease in the country. There was another study that was done in China that looked for coronavirus antibodies, and so they looked at 285 people who were hospitalized with severe disease, and 100% of those people developed IgM antibody within 2 to 3 weeks, but only some developed IgG over a period of several weeks. And again, we don't know if that antibody was protective, so we're still trying to find out how to interpret these tests in the best and safest way possible. And then Israel just recently isolated a coronavirus antibody, a monoclonal coronavirus antibody, that they may be able to use as a weapon against the virus to be able to treat people with monoclonal antibody therapy. So that's something that we might also be hearing more about in the near future. Some of you may have heard about Remdesivir. That is an antiviral that was developed for Ebola specifically, but turns out it has pretty good activity against SARS-CoV-2 virus and is pretty well tolerated. It does cause some transient transaminitis that reverses when the medication is stopped. But there have been a couple of promising trials now that have been done. One was a randomized control trial of 1,063 patients that showed about a third of them recovered more quickly and dropped their mortality rate from 11.6 to 8% versus placebo. The other was a study that was done by the manufacturer that was looking at length of treatment and safety and efficacy, and showed that either a 5 or 10-day course was relatively similar in its ability to reduce hospitalization. They're in the process of expanding that trial, but as a result of these two trials, this drug has gone from having compassionate use through FDA, where they were using it in critically ill pregnant women and children, to now having an emergency use authorization so that it can be used in other populations. Tennessee just received their allotment of Remdesivir, which amounts to enough to treat 36 people. So they're now going through the very difficult process of deciding how you determine who gets that drug and who does not. And we're actually working with Tennessee Hospital Association to try to determine which facilities are going to be able to get that 36 patients worth of Remdesivir. But we know they're ramping up production of that, and hopefully it will be more widely available. And it's not going to be a magic bullet. This is an IV drug, so it's not going to be the Tamiflu of COVID-19, unfortunately. Just some quick information about COVID-19 in children. So I sit on the board of the American Academy of Pediatrics, representing the Southeastern United States. And AAP has compiled some data from the 48 continental United States plus New York City, District of Columbia, Puerto Rico, and Guam to look at the incidence of COVID-19 in children. And so right now, nationally, it's about 2.2% of cases, which is very much on par with what we're seeing in Tennessee with our children, with an incidence of about 22.4 child cases per 100,000 children. So it's still not identified in a lot of children. As medical providers go, we're doing pretty well in that, our population is probably one of the safer populations that medical providers work with right now. There was a study that just came out from China. That this is a pre-publication. It's been approved for JPEDS, but hasn't yet been published, showing that about 50% of the children they looked at in China who had COVID-19 infection were co-infected with other common respiratory viruses like rhinovirus, and that about 27% of those kids were asymptomatic, but by and large, they did not suffer the kind of severe respiratory condition that we see with the adults. And they reported that only one of their 74 children that they studied ended up having severe pneumonia as a result of their infection. But I know a lot of you are aware of the new news that has come out around this Kawasaki's-like illness that's associated with COVID-19, with New York City reporting their first death in a 5-year-old child just here in the last week or so. And now there's been more than 100 children identified in several states. We've not yet been notified of a child in the state of Tennessee that may have this, but it's certainly concerning. And I think about this when folks are talking about, well, we should just open everything up and not worry about it and let the infection hit who it's going to hit, and let everybody get antibodies and maybe herd immunity, and that's how it's going to stop. Because we can see these types of things, and we really don't know what this infection is going to look like long-term in children. We know, for example, with diseases like measles, that if you survive measles for the next 3 years, we know that your immune system is relatively wiped out from being able to combat other common infections, with somewhere between 40 and 60% of antibody being lost. And so all-cause mortality for children who have survived measles goes up significantly because of the measles infection, even though they're dying from other reasons. And this may be a similar kind of consideration. So, and then we also know that kids who survive measles and then survive that 3-year period where their immune system gets hit may go on to develop subsclerosing panencephalitis, which is at this time uniformly fatal. So we don't know that allowing massive numbers of people to be infected is going to be safe, even if they survive the acute period of their disease. So this has now been called the pediatric multi-system inflammatory syndrome, or an atypical Kawasaki type disease process that's presenting with prolonged fever in some, but not all. Difficulty feeding, or anorexia, inability to drink in young children, a lot of abdominal pain and GI distress. Some of the kids have had rashes. Some of them have had the typical hands and feet kind of presentation that you see with Kawasaki's. They have chest pain. They may have multi-organ system involvement. And it is truly an atypical kind of presentation for Kawasaki's. So this is rare, but not uncommon, if that makes sense. So you're very unlikely to see this, we think, because the chance of seeing a kid with COVID-19, we think, is small, on the order of 22 out of 100,000 kids, but we have no idea what the incidence of this is going to look like. And so some kids are presenting with this as their diagnosis for Kawasaki. Some are, or of COVID-19, some are presenting with more typical COVID-19 symptoms and developing this later. And not all kids that are developing this particular syndrome have a confirmatory test that shows the infection with SARS-CoV-2. So it's all very muddy at this point. New York has put out a call for cases to other states so that they can try to start to assemble this data. This is a very similar process that goes on as to what happened with EVALI last year, where a call for cases was put out to try to find people who were dying from vaping or being hospitalized because of vaping. And then we suddenly amassed this enormous number of cases that gets investigated. Similar processes going on through CDC and other states to try to determine what the impact of this is. I wanted to go a little bit through what's going on with vaccine development. Some of the numbers we've heard is that we need to be looking at something around 80% herd immunity. And if getting the infection is not the ideal thing, then we're going to have a vaccine. So just a quick overview when vaccines are in phase 1 trial, that's really looking at safety. It's very low numbers. And that trial is usually not in any way beneficial to the person who's enrolled into the trial. Phase 2 looks at safety and dosing and expands to a few more people. Phase 3 is looking at safety and efficacy and expands to a much broader pool. Then that goes through FDA approval, and then you get into your phase 4 large population studies with ongoing surveillance and evaluation. So there are a few phase 1 vaccines that are in development right now. One is from China and CanSino, and this is a recombinant vaccine that's using an adenovirus vector. So similar to some other recombinant type vaccines that we already use. And they are looking into moving into their phase 2 trial. There's one at the University of Oxford that is in a chimpanzee adenovirus vector. And the reason that they chose that chimpanzee model was because they feel like it's very immunogenic. That is a vaccine that was previously developed for MERS as well, and they've used a similar kind of technology. This one is funded through the government of the United Kingdom, and when they exposed some rhesus monkeys to this, or inoculated them and then exposed them to what they called heavy quantities of the virus, they were all well 28 days later. So they're now expanding that into a larger population of people. There's a vaccine that's a DNA vaccine. This one is super Star Trek-y. This is out of Inovio. And what this does is injects the DNA vaccine into the host, and then that DNA is used to make the protein that the body then creates the antibody to. So it's a different way of thinking about vaccines. So you inject DNA into the person. The DNA is used to make a protein that is similar to what is seen with the coronavirus, and then that is what causes the antibody to be formed, and they inject the vaccine through what they're calling a smart device. So that's very interesting. They have their enrollment, and they're hoping to have some results sometime next month. There's one from Pfizer, which is now in conjunction with a company called BioNTech, and this is an mRNA-based vaccine. We have not had mRNA vaccines used in humans before, and they're actually developing 4 different types of mRNA vaccine, and they're evaluating all of them at the same time. This has just moved into trials in the United States and Germany. And then there's one more from China, which is a formalin inactivated alum adjunct, can't even say it, adjunct, all right. It's got an adjunct, there you go. And they're using a randomized control phase 1 trial for that one, looking at different dosages. So those are all the phase 1 trials. They've got a long way to go. There are 2 that have moved into phase 2, which is looking at safety and dosing. One is Moderna, which is considered to be by many kind of the front runner for getting a vaccine out quickly. This is and also an mRNA mRNA vaccine, which has again not been used in humans before, but they've had some promising early studies. They're doing that out at Kaiser in Washington State, and they expect to have a phase 3 trial starting early this summer. This is the vaccine that they think we might have available in small dose releases to give to first-line healthcare workers by late fall of this year. And then a second one is out of Beijing, which is an inactivated COVID-19 vaccine, very similar to killed attenuated virus vaccines that we've seen before. And then there is a phase 2 to 3 trial going on with the BCG vaccine for tuberculosis. So this one is being randomized in Australia and the Netherlands, and they're looking to see if this is effective. But what they've noticed is that there appears to be a lower attack rate of COVID-19 or of SARS-CoV-2 in countries that inoculate their children with BCG vaccine, and they're trying to figure out if there's some protective element of that vaccine. So since it's already an approved vaccine, it got to skip some of the early phase stuff and move into just looking at how this might impact COVID-19. From the State Department of Health, as far as what our priorities are at this point, we were doing a lot of drive-through testing for anyone that wanted to come and get a test across the state in local health departments. They're still doing that testing during the week. So if you want to go get a test, you can go to your local health department and they will swab your nose. But we've been charged by the Unified Command Group and the governor to do more population-based testing. We've been asked to test all of the long-term care facilities across the state, which is about 700 facilities, to look at testing in public housing, where we might have populations that are not being tested, and therefore we might not be getting a good picture of what's going on there. BIDD, the congregate homes for those with intellectual disabilities, DCS, housing, lots of different types of populations that we're being asked to go in and test. We are rapidly trying to ramp up our capacity to do contact tracing. For each of these individuals that gets infected, there are a number of contacts that we have to trace, and that takes an incredible number of people, probably on the order of thousands, to do that work. We are still standing up an alternate care site in case we should have surge this, we're looking to fall and winter when flu comes back. In case we swamp the healthcare system at that point, we have to have a place to put people who are stable enough to be moved to an alternate care facility, but not stable enough to be moved out of a hospital. There is one in Memphis that's being stood up that has about a 400-bed capacity. We're also going to be using Nashville General Hospital as an alternate care site. The one in Memphis actually is an old newspaper factory, so that place is having to be completely built out by the Army Corps of Engineers, and they're about 80% done. They think they'll be moving beds into that facility next week. And then we've been working really hard on procurement of supplies because PPE has been hard to come by a lot of folks, as is testing supplies. The entire world is competing for the same supply. That's starting to loosen up a little bit now, which is nice, and hospitals are starting to be able to get their own PPE without having to use Strategic National Stockpile or what we have at TEMA. But small providers, I think, are still struggling because many of the companies have very large minimum quantities that have to be purchased. There is an interactive map on our site at tn.gov. If you go to the red bar at the top of the page, that's the governor's page. You can scroll down to testing sites, and there's this cool interactive map. You can click on all of these locations and hover over them, and it'll show you where the testing sites are across the state that are there permanently, and show you the hours and availability of those testing sites. And then I just wanted to spend just a couple of minutes talking about some of the collateral damage that we're seeing because of this pandemic. One is the dropping rates of immunization that we're seeing, not only across the country, but here in Tennessee as well. New York is reporting that in the month of April, their vaccine ordering was down by 76% by their providers. So if vaccine ordering is down, it means providers aren't giving vaccines to kids. And New York, while a hotbed of COVID-19, was also recently a hotbed of measles. So we're very concerned about the risk that we're running in seeing outbreaks of vaccine preventable diseases coming out. So we're trying to get that message out to providers that, hey, you've got to get back to being able to see these kids and vaccinate them, trying to get that messaging out to parents that it's safe to go to their doctor's office and the importance of vaccine. We're launching a commercial that starts tomorrow across Comcast, across the state, which delivers that message, the importance to parents that they need to be getting well visits and having their children immunized on time. We've seen increases in domestic violence and child abuse nationally as well as in the state, and alarmingly, the number of calls to the hotline for child abuse reporting have dropped by about half, which is concerning because not only do we know that the abuse rates are going up, but we know the reporting is down significantly. So that's very worrisome. We're seeing some reports now of increasing postpartum depression in mothers who have delivered because of all the anxiety around delivering a baby in this environment. We're seeing more home births, which are obviously not what we would consider safe, and we want to make sure those babies are delivered in hospitals. I also was on a call with St. Jude the other day who said that cancer diagnoses in kids are down by 50%. And it's not because cancer went away, it's because these kids aren't coming in. And so we're going to see a lot of really late stage cancers showing up in kids, which is also going to be really unfortunate. And then when we're looking at back to school, which is on a lot of minds, it's really easy to shut things down. all at once make a sweeping decision that everybody goes home and stays home. Opening up is very, very different, and this is going to be done on a local district community kind of level if it's going to be done well. So when Pickett County has one identified case and the other, Hancock County has none, it's really hard to say, no, you can't go to school in the fall. And we need to be looking at how different communities can safely go back to school and their activities based on what they know about community transmission in their area. And that's going to be looking at the age of the kids, how many cases are around, what community transmission looks like. In the case of teachers, more than 50% of our teachers are in that at-risk population age-wise, as being 50, 60 and up. So there's just a ton of considerations, and national and state guidelines aren't going to be super helpful in trying to determine what that looks like. So this is how you get a hold of me, michelle.fiscus@tn.gov. I try to be really responsive to emails. You're welcome to contact me if you have questions. You can also go to those websites to look at our daily updates, and CDC updates things constantly. And we got a couple minutes for questions if anybody has anything. Thank you for the opportunity.
That was an amazing update, Dr. Fiscus. Thank you so much. I did have one question as I was looking and listening to your vaccine piece right at the end. Given the fact that we're probably behind on vaccines, given the fact that so many families are not coming in, and knowing what we ran into with the measles outbreak last year, even in the state of Tennessee, is the recommendation to catch up with that second measles vaccine? We know that it can be done as soon as a month later. So when we're seeing these 2-year-olds, 2.5-year-olds, 3-year-olds coming in for their well checks, has the state set anything out as a recommendation saying make sure you're catching up that second measles vaccine?
Yeah, that's a great question and a great consideration. And I haven't heard any chatter around that coming down from CDC at this point. But I think it's a really important consideration, especially if you might have families where you worry about their ability to come back and be seen again. But so at this point, the state's not putting anything out, nor is the VOC program. But if I hear anything coming down from CDC around that, we'll be sure to get that out quickly. And I see there's, make sure there aren't any questions in the chat. Nope, just other kinds of chat.
Hi, this is Dr. Kumar. I'm one of the pediatric hospitalists. Thank you so much for that lecture. It was very enlightening, and lots of things, despite all the information we get that were new to me. I really appreciate it in a more local angle. On the basis of the local angle, and you mentioned this about the schools, community by community, which makes complete sense. What are your thoughts? So, I do think the governor's plan, Tennessee Pledge, I think it's called, is appropriate for where we are, right? Where we're here in Northeast Tennessee. But similarly, what are your thoughts of doing a statewide kind of opening versus a community by community opening? I wonder if what's right for here is right for Memphis and vice versa, or Nashville as well.
Yeah, I agree. I think it's very different when you've got the kind of burden of disease that we see in Nashville and the counties surrounding Nashville, and then in Shelby County, compared to the rest of the state, where there can be single-digit numbers of cases in other places. It's really hard to just put out a blanket recommendation. I think that's where a lot of the pauses have been. So, for example, there's not good guidance around camps yet. And, we've got camps that are slated to start end of May. And I think everyone is kind of waiting on CDC and American Camping Association and the state. And, a camp that is at Vanderbilt University in Nashville looks very, very different from a day camp that might be in Johnson City, which looks very different from an overnight camp that might be somewhere else. And so, and it's the same for things like sports participation. So a sport is not a sport. Wrestling is probably a no-go for this year in most cases. Track and field might be just fine. Golf, cross country, if you stagger starts, you know, there's so much variation. And so I think everyone's trying to provide as much guidance as they can around opening and what you do in all of these kinds of different situations. And I think it just needs to be so much more granular than that, where you've got certain recommendations that are universal, like everybody's got to wear a mask. You just have to. But then, and probably overnight camps are not going to be a good idea, because those kids are going to come from all over the place and all these different geographic areas. But if you're in a small community with a small camp with small numbers that can break out into small groups, and do hand sanitizers and have the adult staff masked, and are in a community where you've got relatively low to none in the way of cases or spread, and you're not bringing in children from outside that community, then I think that can look really different than, you know, kind of the blanket plans that everyone's trying to put out there.
Thank you.
Thank you. Any other questions for Dr. Fiscus? Well, and I know we all have a barrage of questions, but we can email via CME to Dr. Fiscus. Dr. Fiscus also does a weekly Tennessee Department of Health call, I think 1 to 2 Eastern time, 12 to 1 Nashville time, where a lot of this really useful information is presented, if anyone is interested. Thank you once again, Dr. Fiscus, for joining us. This was amazing. And if I can remind everybody to please sign on via the CME website and complete your evaluations, because that's how we're able to continue to bring these wonderful programs to everyone. Thank you all. Thank you again.
Thank you for the opportunity. Y'all have a great day.
You too. Bye-bye.